This week on the Four Rivers Ag Report, is there a doctor in the house? In town? In your county? We'll talk about the issues of getting health care closer to home. And Macon County won a prize worth having. And I'll wait until the doctor leaves before I give you the best news I've heard in a long time. All that and much more on the Four Rivers Ag Report. Welcome to the Four Rivers Ag Report. I'm Fred Peralta. Well, we've seen it all this week. We had cold and damp, we had very damp, almost 2 inches of very damp, and now hot and steamy. Somebody mentioned that the rain this week might have been $1 million rain, and if so, please consider donating just a little bit to WEIU. The big national news in agriculture was the Farm Bill moving out of committee, and next week we'll be talking about what's in and what's not. But this week we had a hard time finding a grain producer to talk to, so we're going to talk about consuming, healthcare that is. The population in our area is spread out and the demographics are skewing older. Nothing new, right? Well, neither is, unfortunately, the drift of healthcare providers away from rural areas to population centers. So what are we going to do? Well, we're going to talk to Dr. Robert Good of Carle Clinic in Mattoon. And Dr. Good has headed several efforts to improve the healthcare access for everyone in our area. Dr. Good, can you describe some of the problems that we face when trying to meet a medically unserved area such as rural Illinois?
Well, I think there's several problems, Fred. One is the cost of medical education. Today, a private medical school will probably have a total cost of their educational program between $300,000 and $400,000. In a public education perspective, if somebody totally goes through a public undergraduate and graduate program, it's $180,000 to $250,000. So it's a substantial debt that a young person develops. It makes it difficult for a person living in rural America to go to medical school and face that type of debt. And so that kind of predisposes medical schools to people from urban areas.
Or people who can afford that much debt.
People can afford. And that makes it less likely that culturally they'll be able to adapt to the rural areas. Furthermore, they tend to find spouses, which tend to be less rural, and you have to have a happy wife, or a happy husband.
Exactly.
So that's an issue. There's, in today's scenario, about 50% of medical schools are women.
Right.
And so they are also less likely to practice in rural areas. And that creates a further shortage. The residency training programs, that's part of medical education. Once you complete a 4-year undergraduate degree, 4 years of medical school, now you have 3 to 4 to 5 years of residency, of training program beyond medical school. And the way it's structured economically, hospitals and universities are losing sites because there's fewer primary care people going into those programs. And so there's fewer places to train them within primary care. So that adds to the dilemma.
What about demographics in these areas? Does that affect the physician shortage?
The rural population tends to be older and tends to be poor. And that reduces the payment that physicians can receive in a timely fashion. So Medicare pays significantly less than most insurances, and Medicaid pays slower and less. And then we have a state like Illinois where there's a significant economic problem. The governor is trying, and the legislature is trying to come up with solutions. But these are all very difficult, and it's going to further delay payments. Now, hospital systems like Carle Foundation and Sarah Bush Lincoln are able to, as part of their mission, is provide care for these folks and to help supplement physician incomes.
Right.
So that's really the only way that the process can go on, if you can find a physician who wants to practice in that area.
So with fewer people, you mentioned that older and poorer, so Medicare and Medicaid are much, much more important in the payer mix.
Yes.
How much of a backload does a physician face when they're dealing with patients with those packages?
Well, I think that there is some hope in this doom of what the case you're trying to present and what is actually happening. But there is some hope. And while the medical community has not totally embraced the Patient Protection Affordable Health Care Act
Right.
of 2010, there are some things in that program which will help rural
Good.
citizens.
What sort of things?
One is a 10% increase in compensation for Medicare patients for practitioners that practice in rural areas. Two is development of something called the patient-centered medical home. The patient-centered medical home is a methodology in which a team of practitioners help take care of patients.
Okay.
So that instead of a private physician maybe being able to take 2,000 or 3,000 patients in their panel, now they can have 4,000 or 5,000 in their panel,
Okay.
requiring fewer physicians. That allows them to work with, more carefully, physician assistants, advanced practice nurses or nurse practitioners, nurses, therapists, pharmacists, and other members of the healthcare team.
Okay.
So there is hope that this, as we go down, and many hospitals are preparing for this, to develop that type of activity in order to take care of more people and do it efficaciously.
So you'd have one physician acting more in a supervisory role with...
I prefer to call it a leadership role.
Okay.
That the physician has the education background to lead the healthcare team and allow chronic disease management. You know, a primary care internal medicine physician like myself may have 60 to 70% of the patient load with diabetes, hypertension, other types of chronic diseases. And pretty much the treatment is standardized as to how we care for these folks and can be done in a different manner in which we do it today.
Now, it used to be each town had their town doctor and, made house calls, supposedly, and that sort of stuff. And those sorts of roles have disappeared. Has the business of medicine affected how physicians locate?
Well, I think it's nearly impossible for a primary care physician to go to a small community, and I'm talking less than, say, 4,000 or 5,000 people, and set up a practice today on their own. It has to be done through a healthcare system. The rules and regulations of the federal government, just like in many occupations, has restricted the private enterprise or the private practice of medicine. So the only way it can be done is through a healthcare system. That makes it more, those small towns don't have hospitals, they don't have a lot of other supportive roles, the diagnostics are limited. So if they can hook up to a hospital system, that allows them to have those type of resources.
Excellent.
And put together that type of team.
Right. So,
I don't think house calls are necessarily dead. There are, there's a lot you can learn from a house call. And in my younger days, I did more of that than I do today.
You're the youngest doctor I've ever heard of making a house call.
No, we have members of our staff that make
Really?
house calls, and there's members of the local community that still make limited house calls.
Now, you have been involved in the Coles County Healthcare Initiative. I think that's what it's called.
Coles Community Health Program. Yeah.
Okay. And the goal of that organization is to try and get patients seen easier, cheaper, faster, better, sooner?
The goal of that organization is really to provide healthcare services to folks who have limited access to healthcare. And that access may be limited by their ability to pay or by a governmental payer that is sometimes hard for them to access healthcare. So it was another mechanism of providing healthcare in the community.
And one of the goals is to see people before they get super sick.
Yes, preventative healthcare is really the name of the game. If we can prevent people, keep them out of the emergency room, not allow, treat the hypertension before the heart attack or stroke occurs. Because once that negative event occurs, not only does it terribly affect the patient, but it significantly increases healthcare costs.
Now, that's been an ongoing project of yours for several years, and it's continuing to go on. And I imagine there's a lot of hurdles to get that organized. How can communities band together and try to organize better ways to access health care for their people?
The federally qualified healthcare system allows monies to be available to pay student loans at a reduced rate or at a tax-free rate. It allows a higher rate of compensation for the organization that is providing those types of services. And in that way, small communities might be able to provide some health care through that type of system. It's difficult. We have a state, again, that's very limited in funding. They're slow in paying, even though the federal qualified systems are supposed to be paid first. And the bureaucracy is very heavy, and that makes it difficult, all the stages you have to go through in order to make it work. We've been very fortunate with Coles Community Health Program and an excellent board of directors who are very dedicated to making this work. We have been able to raise funds to help startup funds and develop a structure and cover some of the losses that have occurred. Our community from 2005, when we started the program, until now has lost employment. Our unemployment rate is almost double what it was then. And that means there's more people who don't have health care insurance and are seeking assistance through the clinic. And again, I keep emphasizing that the situation of the state is in providing the resources to keep the cash flow going. So it's a challenge.
Okay, and you've mentioned the physician as leader, as a model, which, and to do that you need nurse practitioners and physician assistants and therapists and home health nurses and all those sorts of auxiliary people. Is there an effort going on to get those people where they're needed?
Yeah, I think that presently the cost of education for a physician assistant, which is generally a master's level, or a nurse practitioner, which as of 2014 will be a doctorate level, the cost of that type of education is much less than medical school, and the duration of time is much less. So that a physician assistant or nurse practitioner will first have a bachelor's degree and then achieve a master's degree, which usually can be done in 2 years' time. So within 6 to 8 years, they're basically completed their education. The current medical education for primary care is at least a 4-4-3 or 11-year cost perspective, and there's differences in the intensity of education. But saying all that, many nurse practitioners and physician's assistants are very able to take care of primary health care, and it's, in my opinion, best done when they have an excellent collaborative or supervisory relationship with a physician.
Now, last question. What would you say to a young person considering a medical career from a rural area?
I'd say do it. do it. And I think that the good news is the world is changing. We are adapting to what we've been given. There's a great need for health care. The need is there. If you're mission driven, this is the mission. And I believe that we will find a way as a country to provide health care to the rural areas and to do it with high quality. So yes, I believe there's a great need. There's more medical schools. In the last 3 to 4 years, there's been probably 15 to 20 new medical schools around the country. Many medical classes have increased their size. We have a lot of challenges to keep medical education quality and to keep the residency programs where they're quality and accessible to our graduates. But yeah, I think that medicine is still a great career. And after 35 years, this is my 35th medical school anniversary this year. After 35 years, I still fully believe that. It's a great profession. We're honored to take care of people who need us. And I think that that's to the young people out there, if they have that initiative to go, to do it. It's not easy, but it's worth the end result.
Thank you, Dr. Good.
You're welcome.
From corn to China to bar-coded bugs, here's Monica with the news. Monica?
Thanks, Fred. I'm Monica Becker. Many crop watchers expected something like this, but the USDA announced this week a variety of large corn and soybean purchases to China and unknown destinations. On Friday, 1.4 million metric tons of corn for the 2012-2013 delivery were sold, most likely to China. The USDA reported the sale was to be one of the largest single purchases of corn ever. Another 120,000 metric tons of corn were sold for delivery to China for this year, and another 226,000 tons of new crop soybeans were sold to China or undisclosed purchasers. It was sales like that one that makes the CME Group's announcement not at all surprising. It was announced on Tuesday that the Chicago Board of Trade Grain and Oil Seed Futures and Options Market will expand electronic trading hours. Starting May 13th for trade date May 14th, market access for corn, soybeans, wheat, soybean meal, soybean oil, oats, and rough rice futures and options can be traded on CME Globex for 22 hours a day. This may have been the reaction to the Intercontinental Exchange Inc., who also announced expanded grain futures contracts trading. And because you can't have corn futures without future corn, the USDA's National Crop Statistics Services released their weekly report, and it shows that you guys have been busy. The 79% of anticipated corn has been planted in Illinois by April 29th, way ahead of the 5-year average and last year's pace. And that corn is growing, with 34% of the corn having emerged. And because so many of you are done planting your corn, soybean planting is also ahead of schedule, with 13% planted statewide. In our area, we're at 76% corn planted, 53% corn emerged, 14% soybeans planted, and only 2% of soybeans having emerged. And when it's emerged, how are we going to fight the things that want to eat the crops? Well, the USDA scientists have developed a new idea to help identify and monitor insect pests: barcodes. And no, not the supermarket scanner barcodes, but DNA barcodes. The scientists sequence a designated part of an organism's genome and produce a DNA sequence that can be more easily and quickly compared. The faster a pest can be identified, the faster pest management decisions can be made. The DNA barcode system is thought to be superior because different species of insects often look very similar and can have drastically different effects on crops. Presently, the USDA is developing a catalog of DNA information on insects and hopes that continued research will result in faster implementation. You might not think so if you drive by a certain soybean processing plant, but Macon County got some great news this week. The American Lung Association has named Macon County as one of the cleanest counties in America. Macon was rated #1 for the cleanest metro area in the country for both ozone and 24-hour particle pollution. And it ranked 56 out of 277 metropolitan areas for annual particle pollution. The Lung Association reports that 4 out of 10 people in the U.S. live in counties that have unhealthy levels of either ozone or particle pollution. So go outside and take a big, deep breath, Macon County. You've earned it. I'm Monica Becker. Thanks for watching.
Lately, it seems that every end of the month weather summary by Cameron could end up in Ripley's Believe It or Not. And April is no exception. With April details, here is Cameron Craig with Under the Four Rivers Sky.
It has been a roller coaster ride for the climate this spring. March was much like summer, and April went cold. It is almost as if March should have been April, and vice versa. In fact, April, for the first time, was cooler than March. Let's start with March to set the story in motion. March 2012 had an average temperature of 59.1 degrees, putting it 16.9 degrees above the 30-year average. March ended dry. The overall average temperature for April was 57.7 degrees, which was 3.9 degrees above the 30-year average of 53.8. The total precipitation for the month was 4.79 inches, putting it 1.05 inches above the 30-year average. That helped to improve dry conditions throughout the region. The month began with summer-like temperatures for the first 3 days of April. On the 4th, the daytime high dropped to 78 degrees, and the region would not see daytime highs in the 70s until the 15th. On the 11th, the overnight low dropped to 28 degrees, and this would be the last frost. Farmers feared the possible damage to early crops, and then there was some damage to vegetation throughout the region. Daytime highs would jump back and forth between the upper 60s to upper 70s the 16th through the 20th. Then temperatures dipped right back down into the upper 50s and mid-60s the 21st through the end of the month, with a couple of days where highs hit the mid-70s on the 25th, the 26th, and the last day. Drought conditions began to take shape across the north-central counties. Precipitation for the first 13 days of the month only totaled 1.19 inches. On the 14th, a downpour of 1.73 inches fell across the region, helping to keep the Four Rivers region above drought conditions. Dry conditions once again moved in with only 0.64 inches of rain from the 15th through the 27th. The last 3 days, 1.23 inches of rain fell off and on as storm systems pushed through, helping to reverse dryness. The cooler temperatures were due to a persistent trough over the Midwest, putting the jet stream to the south. Cooler Arctic-like air filled in, dropping our daytime highs to near normal. By the end of the month, the active jet began to show signs of migrating again to the north. So what does the month of May look like for us? Temperatures for May will be near normal with below normal precipitation. The next 3 months, temperatures will hold near normal and precipitation will be normal as well.
Now, before I go on with this next story, remember medical research ebbs and flows back and forth. I remember a time when fish oil was good, then it was bad, then it was eh. So take this next story with a major grain of salt. Wait, salt isn't good for you, or is it? Anyway, in the March 26, 2012 archives of internal medicine, researchers from the University of California, San Diego published a study that reports, now wait for this, there is an association between more frequent chocolate consumption and lower body mass index. You heard me. More chocolate equals lower BMI. The study hypothesized that the benefits of modest, frequent chocolate intake might extend to reduced fat disposition, potentially offsetting added calories. It has something to do with antioxidants, phytonutrients called catechins, and insulin sensitivity. Researchers do say because chocolate is consumed as a sweet and bears calories, there is concern related to its intake. But any study I can cite to my wife on the benefits of me having chocolate, Well, I think I know who I'm nominating for next year's Nobel Prize. So that's it for this week. Work hard, be safe, enjoy the beautiful sunsets, and possibly a piece of chocolate. I'm Fred Peralta, and thanks for watching the Four Rivers Ag Report.